students, this is Dr. Prats and welcome to my channel. We are discussing caries and today we are going to discuss classifications of caries based on several criteria, and we are going to discuss enamel caries in particular. Let's roll. So as always, we follow a questioning format. We've already discussed what is caries and why we need to study, because that's what answers our bread and butter. We've also studied the etiopathogenesis, but today we are going to see how to classify caries, how to diagnose it using radiography and histopathology, and also how to treat enamel caries in particular. At the end, we are going to discuss summary of whatever we learned today, followed by a multiple choice question and strategy to answer it. Every lesson must have an objective. At the end of this presentation, you'll be able to classify caries, you'll be able to describe the spread of caries. Zones of caries is nothing but the histopathological appearance of caries, and we need to understand it in order to be able to treat the caries. Later, also, you'll be able to discuss diagnosis and the treatment of caries. So let's start with the classification. According to the rate of attack, it is classified as number 1, acute. Acute, the word itself says, it is very, very rapidly progressing caries. And they say that when it involves more than 10 teeth within a year, then that is termed as acute caries. And there is very limited time for any kind of protective mechanism for the body to make. That is nothing but this sclerotic dentin. So there is no protection, and that is why the caries spreads very fast. This is very specifically seen in relation either post-radiation as a treatment to head and neck cancer, or even associated with xerostomia, which is seen in Sjogren's syndrome, or maybe any kind of salivary gland disorder. So since the first classification is acute, it is logical that the second has to be chronic. So in this, there is sufficient time for defense, so the body produces sclerotic dentin, and that's how the spread is kind of delayed, you can say, and that is how the caries is stretched over a long period of time. There is something in between that is called as arrested caries, that is, the caries begins, but because of the reasons like remineralization, especially from the fluoride which is present in the saliva and also in the diet which you are taking, the caries becomes arrested, that is, it does not progress further. Another reason could be that there could be a lack of food retention. When I tell you how the arrested caries looks, you will understand how this happens. So arrested caries is smooth, hard, polished, and it is deeply stained either black or brown in color. And because it is smooth and polished, the food is not retained basically. And that is the reason the caries might become arrested. So this is the classification based on the rate of attack: acute, chronic, and arrested. This is important for you from the treatment aspect in restorative dentistry. So we need to know what is the G.V. Black's classification. So class 1 is what occurs in the pits and fissures of the occlusal surface, or even any defective grooves which are present on the tooth surfaces, deep developmental grooves. Class 2 caries is found on the proximal surfaces of both molars and premolars, it is your posterior teeth. Class 3 occurs on the proximal surface of anterior teeth. There is a catch in this, it doesn't involve the incisal angle, and when it does involve the incisal angle, it is called as class 4 caries. And class 5 is what occurs on the gingival 1/3 of the labial and lingual surface of both anterior and posterior teeth. And class 6 occurs on the cusp tips of posteriors or incisal edge of anteriors. So that's the G.V. Black's classification. Now let's see how it is classified according to the site of attack. I think this is the easiest. Pits and fissure, because it involves the pit and fissure of the occlusal surface of posterior teeth. Smooth surface caries, as it involves the smooth surfaces, that is your labial, lingual, and the proximal surfaces. And root caries, or it is also called as cemental caries because it involves the cementum or the root. So this is a classification based on the site of attack: pit and fissure, smooth surface, and root caries. So the pit and fissure caries and the smooth surface caries have a certain appearance based on how the lesion starts and how it spreads. So let's see, in case of smooth surface caries, it is triangular or conical in shape, with the base towards the surface of the enamel and the apex pointing towards the dentino-enamel junction. Whereas in case of pit and fissure caries, as you can see, this is the pit and fissure and this is the dentino-enamel junction. The triangle is rather the other way around, or the conical shape. The apex is towards the enamel surface or at the pit and fissure, and the base is towards the dentino-enamel junction. So that's the appearance in case of pit and fissure caries. Why this is in this direction is because of the direction of the enamel rods, basically. So let's see how that happens in the future slides. So when the carious lesion starts, you will see a kind of opacity or a chalkiness which progresses to turn to yellow, brown, or blackish discoloration. Enamel rods flares laterally in the bottom of the pit and fissure, which is the reason for the triangular appearance. So as you can see, enamel flares laterally in this pit and fissure direction. So once the enamel caries starts, it spreads laterally, so the triangular base is at the dentino-enamel junction and the apex stays at the pit and fissure or the surface of the enamel. So this is what you see here. And because of this reason, it produces a greater cavitation when compared to the smooth surface caries, because the enamel rods are flaring laterally. Of course, when the enamel caries is not treated, it turns into dentinal caries as well. It spreads to the dentin. So this is how the spread occurs. So in this scenario, you can notice how the base of the two cones or the two triangles are meeting at the dentino-enamel junction. So in enamel caries, the apex was towards the surface and the base was towards the dentino-enamel junction. And in the dentinal caries of pit and fissure caries spread, you see that the base is at the dentino-enamel junction and the apex is towards the pulp. This is again because of the direction of the dentinal tubules. This brings us to the next classification, that is according to the hard tissue involved. It is classified as enamel caries or dentin caries. So we're going to discuss enamel caries today. So the carious dissolution always starts in the center of one end of the crystal and develops anisotropically along the C-axis. And after the formation of the central hole, the dissolution extends as lateral localized destruction towards the external surface. So this is a very smooth electron microscopic description of what actually happens in case of enamel caries. This is something we do not really see under a normal microscope. And they've also noticed that there is a preferential loss of interprismatic substance in case of enamel caries. So let's go to the histopathology of enamel caries. So the histopathology is given as zones of enamel caries, and these zones are classified depending upon the pore volume and the mounting media which is used. These zones start from the advancing front of the lesion, that is from the dentinal surface towards the outer enamel surface. So let's see the zones of enamel caries. So this is the dentin, dentino-enamel junction, and this entire thing is your enamel. You can identify it by the presence of your striae of Retzius, and these are your dentinal tubules. Okay, so the zones of enamel caries are classified, and the first zone is in the advancing front, that is the area which is posing or facing towards the dentin. So the first zone is translucent zone. So this translucent zone is called as translucent because it is clear in appearance, and this is because of the mounting media which is used. And the mineral loss in the translucent zone is 1%. The next zone we see in enamel caries is the dark zone. The percentage of mineral loss in dark zone is 2 to 4%, and it is called as positive zone because it is always present. The third zone is the body of the lesion. This makes up for the biggest zone of enamel caries, as you can see in this image, and the mineral loss in this body of the lesion is 5 to 25%. 25% is what is seen in the center, and at the periphery it might vary. And the surface zone is called surface zone because it's present on the surface of the enamel, and this is usually intact because of the constant remineralization that is occurring. And the two reasons are responsible for this. Number one is the fluoride, calcium, and phosphate, which is present in the saliva, which is causing the remineralization. And the second reason is all the demineralized component from the deeper layers of the caries come to the surface, and that helps with the remineralization as well. So underneath there is a lot of cavitation which is occurring, but the surface appears intact. This is the reason why caries is detected so late, when already the cavitation has proceeded to quite an extent. And this is the reason why we use a curved probe to see if there is any undermining underneath, any discoloration or any kind of a catch, to see if there is cavitation occurring. And this is a picture just to show you the percentage of mineral loss and the sizes of the pores. So in the surface zone, it is quite intact. Body of the lesion has the largest sized pores, and it is also the largest zone in case of enamel caries, and the percentage of mineral loss is 5 to 25%. The dark zone shows 2 to 4% of mineral loss and has very small pores, and translucent zone is the advancing front, showing a mineral loss of 1%. I think this picture is very clear for you to remember. So let's see the diagnosis part. I told you it is quite tricky, and surface zone remains intact until and unless there is a dip in the balance between demineralization and remineralization, and eventually the surface zone also breaks and forms a frank cavitation. But until then, there is only undermining, or there is a cavitation underneath, but the surface zone appears intact. And of course, in some cases, there is bluish discoloration either before or after the frank cavitation. And this is how the enamel caries appears initially, as an opaque lesion. So upon radiograph, of course, if there is enough mineral loss, or if there is enough tooth material which is lost, then we can see the appearance on the radiograph. And of course, eventually there has to be a frank cavitation when it is left untreated for a long time, and that's when usually the patient comes to the clinic. That is why WHO says that the cavitation which we see, or the diagnosis which we do in the clinic, is just the tip of the iceberg, whereas underneath there are several areas which go undetected or undiagnosed and untreated. So let's see. So number one is given to the opacity, which is hardly visible on the wet surface, but after air drying it becomes visible. Number two score is given to the opacity, which is distinctly visible even without any air drying. And number 3, when there is a localized enamel breakdown or there is a grayish discoloration from the underlying enamel. And 4 is the frank cavitation in the enamel exposing the dentin. And this is the stage which actually comes to you as a clinician. And that is why it is very important to detect the caries way early so that we can prevent complicated treatments and we can treat the patient very easily and he can retain his natural tooth structure. So radiographically, of course, it is easier to detect, especially the interproximal caries, because it goes undetected clinically even by the dentist. So only when we take a radiograph we can see that there is a cavitation below the contact area, and that's the most common area for the occurrence of the cavity. This I've already explained to you before. Because of the food stagnation, and unless you're using a floss and you're cleaning your interproximal area followed by a mouth rinse with some fluoride mouthwash, this is bound to occur. And even smooth surface caries, root caries, can be seen on the radiograph as well. Another important diagnosis which takes help of the radiography is the recurrent caries. What is recurrent caries? We've already treated the caries, we've given a restoration, we've sent the patient home, but he comes back with some kind of caries underneath the restoration, that is called as recurrent caries or secondary caries. Many reasons: either there is micro leakage from the restoration, or there could be some cavity which is left behind which has undergone activation and has formed caries underneath the restoration. So these are some of the causes for the recurrent caries. So, like I always say, do not get overwhelmed. Just remember the clinical picture, radiography, and histopathology of enamel caries. So, clinically, in the beginning, it appears as chalkiness or opacity and eventually turns into bluish white color, discoloration, and eventually yellow, brown, or black discoloration. Radiographically, of course, we can identify whenever there is mineral loss, and histopathologically, there are 4 zones: translucent zone, dark zone, body of the lesion, and surface zone. So let's just describe each one of them. So it starts from the advancing front of the lesion. So translucent zone, the mineral loss is 1%. Dark zone is called as positive zone. Mineral loss is 2 to 4%. Body of the lesion is the largest zone, 5 to 25% mineral loss, and surface zone is the intact zone and mineral loss is 1%. So treatment depends on how far the caries has progressed or what's the extent of involvement of the caries. If it is just limited to the enamel caries, we do a cavity preparation and then restore it with restorative material. If suppose it has involved the pulp, then we'll have to do root canal treatment, and if the tooth has gone beyond repair, then extraction or exodontia is the treatment of choice. This is, of course, when the caries proceeds, and if it is just limited to enamel, then restoration with composites is the treatment of choice. Of course, we can avoid pit and fissure caries and even smooth surface caries for that matter by using fluoride, either in the form of tablets or you can use trays for topical application of fluoride. So an MCQ which could be asked here is, which of the following zones of enamel caries is called as positive zone? Most of the people get confused in this matter because they know body of the lesion is the largest zone of enamel caries, so they think that that is probably the positive zone and it is always present, but it is actually dark zone which is called as positive zone because it is always present. These are my references, students. If you liked how I explain everything, how I discuss the strategies of solving an MCQ, then please subscribe to my channel and share it with your friends. And more importantly, tell me what are the other topics which you want me to teach for you or help you with, and leave your doubts in the comments below so that I can clear those doubts for you. And if you like my MCQs, you can go to my website. The link will be given in the description box below, where you have several such MCQs for you to practice, and you can get ahead of the game. Thank you and keep smiling.